Good afternoon, everyone. My name is Julie de Kock, and I will be the moderator of today's webinar. It is my great pleasure today to welcome Dr. Patrick Tang as our speaker. Dr. Patrick Tang is the Division Chief of Pathology Sciences at Sidra Medicine and an Associate Professor of Pathology and Laboratory Medicine at Weill Cornell Medicine in Qatar. In addition to his clinical role as a consultant medical microbiologist, he is also responsible for the development and implementation of new molecular and genomic-based tests for infectious diseases at Sidra. Prior to him joining Sidra, Dr. Tang was a clinician scientist leader at the British Columbia Centre for Disease Control and also a clinical associate professor in the Department of Pathology and Laboratory Medicine at the University of British Columbia. Before we start the seminar, I have a few housekeeping rules that I would like to remind everyone of. First of all the attendees, their microphones have been muted. And second, I would like to invite all of you to submit your questions through the Q&A tab, so not a chat tab. And if you submit them in the Q&A tab, make sure you address them to all attendees so that we can capture them. Today, Dr. Patrick Tang will give us a presentation and he will provide an overview of the current state of diagnostics tests of SARS-CoV-2 and insights into the ongoing challenges for COVID-19 laboratory testing and how testing can be used to control the outbreak. So without any further ado, please, Patrick, you can start sharing your presentation. Thank you.
Thank you very much, Julie, for the introduction. So today, I'm going to be talking about how laboratory testing can bring us back to some sort of normality during this COVID-19 outbreak. So I'm going to review some of the current status of COVID-19 testing and how the testing is being used to control the outbreak, as well as some of the ongoing challenges and what the future might be for testing for COVID-19. So the world has been plagued by pandemics since the beginning of mankind. The history of the world is really a history of pandemics, and these pandemics have shaped humanity over the ages, and they still continue to plague us. Almost every few years, we have pandemics, despite all of the technology and advances that we have made in medical science. However, for most of history, we had no idea what caused these pandemics. There were theories of things like bad air, miasma causing some of these illnesses back in the 1800s. And we also didn't have the right tools to address these outbreaks. We had things like perfumed masks to try to keep away some of this bad air that people believed was causing some of these pandemics. Nowadays, we are able to quickly identify novel viruses. When the outbreak first started in China, within weeks, they were able to identify the virus and even determine the exact genetic sequence of the virus. We also have the tools to track outbreaks in real time before they even become pandemics. This is a screenshot of the Johns Hopkins dashboard the day before the WHO had declared the COVID-19 pandemic. And we have leadership at a global level as well as a national level. We have public health institutions that follow scientific and evidence-based guidelines. And the message shortly after the announcement of the pandemic was a very simple message that all the countries in the world need to test, test, test. So what does that mean? What does it mean to test for COVID-19? Basically, there are two main ways that we look for this disease. We can either look for the virus. We detect the virus by looking for its genetic sequence, the viral RNA, or we try to detect the antigens that are on the surface of the virus, so the proteins that are on the outside of the virus. The other alternative is to look for the host immune response. Most of the assays that we have look for the humoral response, or the antibody response against COVID-19. So after someone's been infected, they develop antibodies and also T cells that might be specific to COVID-19. Definitely, we don't have very good assays for measuring T cell responses, but there are hundreds of assays out there right now that can measure the antibody response. In the future, we might expect other types of tests to be able to help us. So people are already working on proteomic type assays. So that these are methods where we look at all the proteins that might be in a sample. So there have been researchers that have used mass spectrometry to look at all the peptides that might be in your saliva and try to pick out the peptides that are specific to SARS coronavirus 2. Another promising avenue is the use of metabolomic-based assays. So this is looking for metabolites and small molecules that might be in waste products from the body, so body sweat or your exhaled breath. So there have been some preliminary evidence where we can use dogs to sniff out some of the volatile organic compounds that are emitted in body sweat when someone is infected with COVID-19. And people are also developing electronic noses that can also detect some of these same compounds that are in our breath. However, the main method that we're using right now is real-time reverse transcription PCR. It remains the primary method for diagnosis of acute COVID-19 infection around the world. It is the most sensitive and specific method that we have right now to detect the viral RNA. It's also the most popular. It's endorsed by the WHO and most other public health agencies around the world. And there's lots of different platforms available. This equipment is distributed in almost every diagnostic lab around the world. And we have different formats. We have rapid lab-in-a-box type assays to high throughput systems where we need to extract the viral RNA out and then run these PCR tests on high throughput PCR systems. The advantages of real-time PCR are many. So the first one is that PCR has been around for decades. So because it's been around for so long, there's a lot of equipment available. The consumables are widely available. And over the past decades, we have made many improvements to this technique. We've made improvements to the enzymes that are used. We've made improvements to the machines that are used to do the PCR reactions. And overall, this method is very sensitive, very specific, and the assays are very easy to design. So most clinical molecular labs are able to design these assays by themselves and purchase all the different components to be able to create their own assays. The disadvantage of real-time PCR is that the equipment is relatively expensive. This method requires a very complicated cycling of different temperatures. So the temperature in the machine has to be very accurate, and it has to cycle between very cold temperatures to very hot temperatures, and that's very inefficient and slow. So most assays that involve PCR are also very sensitive to many of the contaminants that might be in a clinical sample. So most assays will require that the viral RNA is extracted out from the clinical sample before PCR is run. And many of these assays are very susceptible to inhibition. So there are components even after RNA extraction that might still be in the sample that will inhibit the PCR reaction. So overall, PCR has very good sensitivity. So if we look at the analytical sensitivity, we look at the limit of detection of these assays, as long as you get about 1 to 10 copies of the viral genome into your reaction tube, you should be able to detect the virus in that sample. And these assays have very high specificity. So I put a very conservative estimate of 95%, but really we're looking at specificities of 99% and higher. The turnaround time for most RT-PCR test is about 3 to 4 hours. So if we're talking about reverse transcription real-time PCR, it's about 3 to 4 hours, because it also includes the time required to extract and purify the viral RNA out from the clinical sample. And there are rapid tests where all of these steps are miniaturized and integrated into dedicated platforms, and these dedicated platforms can do these tests in as short as 45 minutes. So with such good performance, why do we keep hearing in the media and in the scientific literature and medical literature that PCR is only 70 to 90% sensitive for the detection of COVID-19? So there's many reasons for this. So one is that the stage of illness in which you're trying to detect the virus maybe at a stage at which the virus has already been cleared by the immune system. So you're catching the person too late in the infection, so you're not going to be able to detect it readily in the upper respiratory tract. Or that person's moved on to have more serious disease, and the virus has moved on to the lungs, to the lower respiratory tract, so you're not going to detect it as well in the nasopharynx. Most recommended protocols require the collection of a nasopharyngeal swab, and to collect that properly, you have to have very good sampling technique. So if it's not collected properly, you're going to have false negative results. And many of the studies that are claiming these, quoting these low sensitivity numbers have not really been done properly. They've been done in hospitalized patients that are very sick, where the virus in many cases has moved on to the lungs and lower respiratory tract. So if you were to collect an NP swab or a nasopharyngeal swab from these individuals, you're not going to get very good sensitivity. And some of these people might also be at a later stage of illness. So again, you're going to have poor sensitivity in the upper respiratory tract. So what can we do to improve the clinical sensitivity of PCR? So definitely you have to have very good techniques. You have to train the people that are collecting the swab to do it properly. And other things you can do is repeat testing. So if you swab people repeatedly in people that you have a high suspicion of the disease, eventually you'll get a positive test. And you could also take alternative types of samples. So if you're suspecting a lower respiratory tract infection, definitely you should take a lower respiratory tract sample. And in other protocols, the nasopharyngeal swab testing can also be paired with serology testing to look for antibodies, which would develop a bit later in the infection. Other suggestions have been to use non-PCR methods, so isothermal molecular assays. And the ones that are most popular that people are looking at right now are various reverse transcription versions of isothermal assays. So the first and probably the most popular right now is RT-LAMP, or loop-mediated isothermal amplification. I definitely don't have time to go over each of these techniques, but basically LAMP is potentially faster. So for positive samples, they can amplify in as short as 15 minutes compared to PCR, which would take a little bit longer. LAMP assays are less expensive than PCR because they require less expensive reagents and less expensive equipment, and they're almost as sensitive as PCR. The caveat to LAMP assays is that assays are very hard to design and optimize. So it makes it difficult to design very good assays for all different types of pathogens as compared to PCR. Another technique that is being used right now is reverse transcription near, or nicking endonuclease amplification reaction. And there is a commercial product out there right now from Abbott that you might have heard about in the news, where they're claiming to detect the virus in positive samples in as short as 5 minutes. And this is definitely a very promising technique, and it has some limitations. And So one of the problems is that in this type of amplification process, a lot of non-specific products are produced in the reaction, and that limits how the sensitivity level that they can set for this assay. And using some of the standard swabs and the transport media that comes with the swabs right now, some of that media that comes with the swab, that liquid that you put the swab into, can interfere with some of these assays. And some of these faults have been very much publicized in the media after the introduction of these assays. So these are just barriers that have to be overcome with time as we figure out how to deal with the issues of the transport media and set better cutoff detection limits for the assays. Another assay that is promising is recombinase polymerase amplification, or RPA. This is a method that has been researched over the last few years for other viruses. And one very good advantage about this method is that it can work at very low temperatures. So you don't need any special equipment to incubate these samples up to temperatures of like 37 to 42 degrees Celsius. These assays are also equally fast compared to the other isothermal assays. So in as short as 30 minutes, you can get results. But again, just like the other isothermal methods, the RPA reaction also produces some non-specific amplification that also limits its sensitivity as well. And one very interesting avenue that people have pursued recently is the addition of CRISPR-based detection methods to some of these other assays. So the one limitation of these CRISPR-based assays is that they first require amplification of the viral RNA by another method first. In the two assays that are being tested right now, they are using RT-LAMP as the amplification method. So first you have to do RT-LAMP, and then you take the products of that amplification reaction and you use a CRISPR-based detection method to confirm the presence of COVID-19. So the current iterations of these CRISPR-based assays are a bit cumbersome. They require multiple steps, of which the final step is the CRISPR-based detection. And they also have similar, very fast detection turnaround times of 30 to 60 minutes. So an alternative to all of these molecular detection assays, so assays that detect the viral RNA, an alternative is to detect the viral antigens, or the proteins that are specific to the virus. So these are very rapid assays that can be used at point of care. They have somewhat lower sensitivity compared to PCR and the other molecular methods, but they're very highly specific. So you're not going to have a lot of false positive results. So the limitation of these assays is that they won't detect people who have very low viral loads in their samples. But it's very sensitive for the people that have very high viral loads in their respiratory samples. So this is going to be a very rapid method that's very useful for finding the people who are most infectious and probably the people you're most interested in from the public health point of view. So these are the people that are going to have actively replicating virus and high viral loads, and the people who are most likely to transmit the virus to other people. If you use these types of assays in a high prevalence setting where many people are positive, there's a potential to also save money, because if you're positive by an antigen assay, then you don't need to run PCR or another more costly molecular method on those people. But the negative people might need to have repeat testing because these antigen assays are not as sensitive. They're going to miss some of the people that are infected. The other caveat about using these assays is that they're lower throughput. So you can only do about one test at a time. So it's definitely not meant for testing thousands of people at one time. You have to then, for that kind of purpose, you have to stick with high throughput molecular assays. Finally, the last type of assay that we have available to us right now are serology assays. So these are assays that detect antibodies that form after you become infected with COVID-19. So this happens shortly after infection, and these antibodies also stay in your blood for many weeks to months after your initial infection. So these antibody tests are more useful later in the outbreak when the prevalence of infection is much higher, so that you don't end up testing lots and lots of negative people. And they're also useful for detecting some of these post-infectious syndromes that we're seeing now in people who've had COVID-19, cleared the virus, and now have chronic symptoms related to the initial infection. The assays that are out there right now have very variable performance. The sensitivity and specificity are highly variable. And the problem is that these assays are very easy to manufacture. So there's hundreds, literally hundreds of these assays out there on the market. And many of them have very poor quality. And they, because of the emergence of the virus in the pandemic, a lot of these assays received rapid emergency use approval. So some of these assays have problems with cross-reactivity. So they might give false positive results of other coronaviruses, or they might give false negative results because the antigens that are used in the assays are poorly constructed or poorly chosen. So one of the types of assays that are out there right now really target two of the proteins in the SARS coronavirus 2. So one set of assays target the nucleoprotein antibodies, and these are antibodies that rise early on in infection. They're very, very sensitive for detection of people that have been recently infected, but these antibodies also wane sooner. So if you wait many weeks to months after infection, you might get a false negative antibody titer. The other class of serology assays target the spike protein antibodies. These ones rise a little bit later compared to the nucleoprotein antibodies, but antibodies against the spike protein are more correlated with protective immunity. And these antibodies also last longer than the nucleoprotein antibodies. So there's different formats of the serology assays out there. There are the rapid assays that we hear about a lot in the media, where they can detect COVID-19 infections in 10 minutes, and many places are also offering these kinds of point-of-care serology assays. Unfortunately, many people misinterpret the results from these assays, thinking that a negative result would rule out acute infection. So that is one of the caveats of these assays, is that during the very initial few days of infection, when you're most infectious, you might not have antibodies yet. So these assays can be run very quickly in 10 to 15 minutes. If we look to laboratory type assays, then we look at things like traditional ELISA assays, which take 3 to 4 hours and have many different steps in there, washing and incubations and things like that. And these are the traditional serology assays that we employ for many other viruses and bacteria. And we also have automated assays. So these are chemiluminescent immunoassays that are faster. So they sort of miniaturize some of the things that happen in a traditional ELISA, and they can complete the assay in 30 to 60 minutes and in a high throughput fashion. So with all of these techniques out there, can testing restore normalcy? It was a very simple message from the WHO. We just need to test. And is that good enough? So we have these rapid on-demand tests available for people that need, for patients that need urgent medical care. They might have symptoms of COVID-19 or other reasons where they need to be tested rapidly. And we have high throughput platforms out there that can support the public health efforts to control the outbreak from spreading within a country. But with all of that, life is definitely still not normal. And life really has changed a lot. So if we think about all the things that that we are missing out there, all the arts and entertainment, sports, so whether it's recreational or professional sports, school is not the same anymore. We have school being conducted online instead of in person, and that's going to have effects on the children out there in their education. Travel is highly cumbersome and restrictive right now. We don't have things like spa services, massages, and other things like that. Many elective medical and dental services have been canceled or postponed. We can't get together with our friends and families anymore. And going to a restaurant is a very risky activity now. And really, one of the important things that we're really missing out is that we don't even get to see each other's faces anymore. And the reason behind this is because we cannot test everybody. Even if we could test everybody with the technologies that we have, we can't keep testing them all the time. Why is it difficult to be able to do testing? And the reason is that testing can be very expensive, and we need to have all the swabs, the protective equipment, laboratory equipment, and supplies to do testing. All the testing that we do and the supplies that are required are susceptible to supply chain disruptions that have occurred many times during this pandemic. We have to also consider the safety of all the people that are involved in the testing process, the healthcare workers taking the swabs, the people working in the lab, they're doing the testing, as well as the patients as they come in one at a time for their test. We also have to have lots of training for the people. They're collecting the swabs so that the swabs are taken properly, and the people that work in the laboratory must also have sufficient training. And when we don't have enough capacity in our system, either for collecting samples or for doing the laboratory testing, that leads to delays in testing. And finally, the tests themselves are not 100% accurate, so that requires clinical oversight and clinical interpretation of the results so that we don't have false positive and false negative results being used for decision making. So some of these problems can be solved. So we can look for less expensive tests. So trying to develop some of these tests ourselves in home brew type of assays and using alternative methods that are cheaper than PCR, like LAMP. We can also try to make our own reagents or design our own methods so that we're not dependent on commercial suppliers and all the supply chain issues. We can also look for point of care testing platforms so that we don't need to send all of these samples to a clinical laboratory where there's a lot of time wasted in transportation, and these labs also have to consolidate many samples and run them in batches, which also slows down the testing process. We can also turn to self-collected samples, so things like saliva, sputum, or self-collected swabs, so that we don't need to involve a healthcare professional to take the samples. And we can also look for faster alternatives to PCR, so looking for antigen tests or the isothermal molecular tests that I talked about earlier. And finally, in the future, we might also have access to new technologies, so proteomic and metabolomic-based assays that could potentially revolutionize the way we do diagnostic testing. So the rapid tests that we have for SARS coronavirus are going to be very useful. And the situations where this is going to be useful are times when we might not be able to wear masks. So as when you're doing sports or other things like that, you can't be wearing masks. And situation where there's mass gatherings and close contact. So it will be important to find out which individuals are infected within that group and be able to identify and remove them. So the caveat with many of these rapid tests is that they might miss some of the weakly positive individuals, but then these individuals are also not very infectious. So then that might not be as big of a disadvantage as we think it may be. The other alternative is the self-collected samples, and this is going to be very useful because the nasopharyngeal swabs requires a trained healthcare professional to take them, and that person has to wear personal protective equipment because during the swabbing process, that generates aerosols that are infectious and potentially could infect that healthcare professional. So the samples that have been looked at in many countries around the world now include saliva or throat gargles or sputum as alternative specimen types. And this is going to be very important in the community where we can't always have a nurse or doctor there to collect the NP swabs. And you're not able to collect these swabs and then wait for the sample to go to a lab to be tested. So when you have self-collected samples, it also improves the compliance of patients and also it facilitates repeat testing. So then when you're able to repeat test, you're able to improve the sensitivity of these assays compared to the gold standard nasopharyngeal swabs. And there have been examples of this out there where people have started doing, community members have been doing these types of tests. So there's one example that's been featured has been in Racine, Wisconsin, where firefighters took on the LAMP testing on saliva samples. And one of the connections here is that one of the scientists at Weill Cornell in New York, his older brother was the mayor of this town. And this is why many people in this town started experimenting with LAMP assays. And in the same state, at the University of Wisconsin, there were scientists there that also took that same idea and turned it into a mobile LAMP lab where they fit all of the equipment into the back of a van, and they could go to schools and other events where there's many people that need to gather together and then do LAMP testing on all of these people to assure and prevent infections from occurring during these events. And we can't forget about PCR too. So PCR is a tried and true methods, and all of these new methods that we're talking about might not be fully developed in time, may not be fully validated, and they may not be deployed in time in a mass deployment that would be able to help us stop the outbreak. So we need to also improve the way we do PCR. So there have been many methods published out there using homebrew methods where you can make your own reagents and your own protocols. And if you introduce a lot of automation into your PCR testing protocol, that can also increase your throughput in a number of samples you can test at one time. So the other way is to deploy these rapid lab-in-a-box systems, so similar to LAMP and other assays out there where you have these small devices that can be used in the community. If we have lots of these small devices, we can deploy them widely and make PCR available in community and point-of-care settings. And we can try to make the assay faster. So there's lots of different ideas. There's even a group of us here in Qatar that have experimented with skipping some of the steps that you need in PCR. So a team led by a scientist in my lab, Mohammed Rubaiyat Hassan, has skipped the RNA extraction step and still been able to do highly sensitive RT-qPCR testing for COVID-19. And there are devices and special tubes that can allow you to do faster thermal cycling, so doing the PCR reaction faster. And there has been a lot of engineering work to make better enzymes for PCR to also allow it to complete these reactions faster. And the other thing that's coming up is respiratory virus season. So with PCR, it's very easy to group together or multiplex together many different pathogen assays together. So if we combine these COVID-19 assays with the other pathogens that we're worried about, like influenza, RSV, and other viruses that are going to come back during the respiratory virus season, this will also make PCR testing more useful. So recently, just over a week ago, the headlines showed this massive pool party in Wuhan. And Wuhan, as you know, was the epicenter of COVID-19. This is where the virus was first detected and first spread across China and then to the rest of the world. And how can we restore normalcy to the state that they're having right now in Wuhan, where they can have these mass gatherings where no one's wearing a mask and they're all in close proximity and they're not worried about getting COVID-19. So one thing is, we need to have cheaper tests. We have $1 home pregnancy tests that are actually very good. They're very sensitive and very specific. So we need the $1 version of the SARS-CoV-2 antigen tests. They're definitely going to be less sensitive than PCR, but they're going to be good enough, and they're going to have high specificity. And having this low cost will allow these tests to be widely available and allow people to do repeat testing to compensate for the decrease in sensitivity. So I mentioned before the recombinase polymerase amplification. There are people working on this right now. And this is a very promising technique because it doesn't require an incubator or anything else like that to do the molecular amplification. So this assay only requires a temperature of like 37 degrees Celsius. So you can use body heat. So there have been studies showing that if you put the reaction tube under your armpit, you can actually do the viral amplification reaction there. And the sensitivity and specificity is comparable to PCR. And they're right now in many places around the world also training dogs to sniff out COVID-19. So this is a picture of a medical detection dog in the United Kingdom where they're planning to use these in the airport. So these dogs have been trained for 8 to 10 weeks to sniff out the body odors that are associated with COVID-19 infection. And the sensitivity is actually not bad. A highly trained dog can have a sensitivity of 80 to 90%, and the specificity is over 95%. And one dog can screen 250 people in an hour. So this would definitely be able to be useful for mass deployment in places like the airport. And there are companies out there, several companies out there developing electronic noses or breathalyzer type tests where they're trying to detect these volatile organic compounds as well as nitric oxide in our exhaled breath. And these tests can return a result in less than a minute. The quoted sensitivity is around 90%, and these tests are going to be cheap, less than $10 per test. So this is also a very promising avenue for diagnostics. So with that, I'm going to finish my talk, and I apologize for the technical glitch in the middle of the presentation, and I'll take any questions.
Okay, thank you very much, Dr. Patrick Tang, for your thorough presentation. And despite all the glitches, we made it in time, so thank you so much for that. So if I can start off with some questions myself, I would like to ask you about the PCR sensitivity. So at the start of your talk, you were mentioning that the PCR sensitivity for COVID-19 is actually not ideal. It should be higher. And one of the factors that would actually affect this is, of course, the sampling technique, if it's done properly or not. But I was wondering, is one of the factors that might also play a role actually be the fact that it's either, because we know the swabs can be taken from the nose or from the throat. So does that affect at all the sensitivity of the PCR assay? Could you comment on this?
Right now is collecting samples from the nasopharynx, so into the nose all the way back to the nasopharynx. So when you use alternative samples like sputum or saliva or throat swabs, you're going to have a slightly decreased sensitivity of detection of people that are in that initial phase of infection, but it might not be that bad. So I think the initial studies where we looked at these sensitivities were done in hospitalized patients. So I think some of the comparisons and the numbers that are quoted out there are probably not fair. So I think the use of saliva and throat swabs could be very useful, especially if we do them more often and we do them in larger numbers of people.
Okay, thank you. Then I have a question that came in from Dr. PK. He's asking how many different determinants do the PCR test currently, and how many antibodies might be needed to test various antigens? I am asking this as I'm assuming that one or two determinants perhaps won't be there in all the samples, or almost all the viruses pretty much the same.
So that's a very good question. So in terms of PCR, almost all the assays out there, the recommendation is to test for more than one target. So all the assays out there test for 2 targets or maybe even more targets in the viral genome. And that's to increase the specificity of the test. Because one of the things that we're finding is that as people recover from the infection, they keep shedding the virus, and the virus is actually inactive, and some of the RNA from the virus has been chewed up. So in some of these people, you might only detect one target and not the other target because the viral RNA has been degraded. So this is very useful when you have multiple targets because you can start to distinguish between some of these different stages of infection, people that are infectious versus not infectious. So that's very useful. And the second question was about the antibody testing, and so right now there are lots of different coronaviruses out there, and they share some homology in some of the proteins that they have, and the ones that they're most distinct for SARS coronavirus 2 are the spike protein and the nucleoprotein. So those are the ones that are commonly used for antibody tests. So almost all the commercial assays out there target one or both of these targets in the virus.
Okay, thank you. Yeah, I mean, that makes sense. That it's better to target different antigens or even different RNA sequences to make sure we don't miss anything. I had one more question related to antibody titers. So you did mention the serological testing, but there are different reports out there that are actually saying that antibody titers are dropping quickly within a couple of weeks, maximum, let's say 2-3 months. So does that mean that we're actually looking more in the direction of protective T-cell immunity? And if so, what kind of assays can we have for those? Because again, as you mentioned yourself at the start, we don't really have any good T-cell based assays at the moment. So where are we heading towards?
So I think there's a lot of worry over some theoretical concerns that scientists have. We know that immunity isn't only based on antibodies, but also T cells. So the fact that we have waning immunity of certain antibodies is not too concerning, and that's normal for almost every other respiratory virus infection that we have. So the fact that the nucleoprotein antibodies wane sooner is not a big issue, and we're finding, and in some of those people, they also still have the spike protein antibodies. But even if those wane, there are memory B cells, memory T cells, and those also contribute to our immunity against these viruses. So I think we're not. If we think about all the other viruses that are out there, and how we develop immunity against them, and the fact that we don't have big outbreaks of all these other viruses all the time, it suggests that we do develop some level of immunity and protection against these viruses after an infection, whether we can measure it or not.
Yes, thank you. I was wondering as well if you can maybe elaborate a little bit more on the metabolic assays. So you were mentioning these odor sniffing dogs. So can you maybe explain a little bit how the virus would affect metabolic assays or the odor of that is related to the virus?
So the metabolomic based assays out there measure compounds or metabolites that are produced during an infection, and they have been and as well as other disease states. So if you train animals to detect, they have been trained to detect cancer. Animals have been trained to detect tuberculosis. So it's no different than all of these other diseases where they change the metabolic processes in the host, and then we have different metabolites that are produced and released in our waste products, and where if you had the right detector, you're going to be able to differentiate someone that's infected versus someone that's not infected. So this is shown very good promise in terms of the use of dogs, as well as some of these electronic nose devices that several companies are developing. But this is something that's been worked on for probably maybe 10, 20 years. So people have had this idea for a long time, and it's taken a long time to get to the stage that we're at. So I'm not sure if some of these ideas will make it and become commercial and viable within the course of this pandemic, but they're very promising.
Yes, and can I just ask you, if you're talking about obviously changes in the metabolites because of the infection, this would not be specific to SARS-CoV-2, correct? It would be more like a virus-induced change. Or is there a possibility that it's specifically linked to the SARS-CoV-2 virus?
So some of these will be specific to SARS coronavirus, and some of them are less specific. So I think many of these assays also measure things like nitric oxide, which is not specific, right? So it's going to be a combination of these different targets that they detect, and in the context of a worldwide pandemic, then you're going to have a better positive predictive value.
Okay, great. Thank you so much. Then I would like to maybe ask the last question before we finish the seminar, and this is more asking for your vision. So you gave us a very nice, thorough overview of all the different assays that we have nowadays and what people are working on. So thinking about that COVID-19 is not going to disappear tomorrow. We have to live with it for some time, and as you say, we will not go back soon to our normal life. We will have a new normal. So having this in mind and having all those technological advancements and new techniques coming up, what do you personally envision that might be the next type of assay to replace what we use now in the clinics, the RT-PCR?
So I think the alternative technique that is most advanced right now is the use of these self-collected samples like saliva, and then pairing it with simpler techniques like LAMP, and that shows probably the most promise for being able to be widely deployed. But then definitely all of these other techniques are far behind PCR because there's so many PCR machines out there around the world compared to some of the other equipment that you might need for some of these other assays. So I think that's one caveat about these new molecular techniques. The other avenue is the use of antigen tests. So I had talked about very cheap pregnancy tests. So there's no reason why we can't make very cheap SARS coronavirus 2 antigen tests. So if there's more interest in this from the companies that make these types of tests, and this is going to be very promising. So the use of antigen tests.
Yes. I mean, as you mentioned, the $1 pregnancy test is quite sensitive. So it would be great if we can have a similar assay for SARS-CoV-2. So with that, I would like to end our session. Again, I would like to thank you very much, Dr. Patrick Tang, for your presentation and for answering our questions. And I very much look forward to what will be the next step in the technological advancements and assays, basically, to see how we can return back to normalcy, thanks to the testing, as you put it nicely. So to finish off, again, thank you so much, everyone, for attending. And thank you, Dr. Patrick Tang. And we have a short survey when you will leave this Cisco event. So please feel free to give any feedback. And I invite you all to keep tuned for our next webinar. Thank you so much.